I know I'm no Mark Cuban, but I hope I will give you a whirlwind tour of what's been going on in Alzheimer's disease and neurodegenerative diseases in general. So a few upfront disclosures. This is related to the work I do with clinical trials, so a lot of pharma representation here. People can't see me behind the podium, so I'm just gonna move around a little bit. It's my genetics and height here. So I know with internal medicine, we've got a lot of different specialties. So for the primary care audience out here, geriatricians audience out here, or even cardiologists who might have a patient come in for a checkup. Here's a potential patient. I pose this as a question to you. I don't know how to do polls, but I pose this as a question to you. This 62-year-old man is coming in for an annual visit, and he wants to know about Alzheimer's disease. Are there tests that we can do? What can we do for him in terms of testing? And your first question and response may be, well, what's his chief complaint? Does he have symptoms? Well, the question and the answer may be different if he does have symptoms or not. But what if he has symptoms that he says, well, I'm having trouble thinking of names. I'm having trouble thinking of words. And I have a family history. My mother had Alzheimer's disease. What then? Are we at a point in medicine where we can and should be doing Alzheimer's biomarker testings for these patients? So, and I think about this now as, again, not a primary care doctor, but someone who comes in for a cardiovascular screen, cancer screen, neurodegenerative screen. Are we ready to do that? And so the next sort of 45 minutes, I'm going to take you through an outline of where I think the data has shown, where potentially we may be, but you can make your own decision and let me know at the end of the talk today whether or not you think we should be. All right, just so that we're on the same page, I'll give you a little bit of background on Alzheimer's disease so we can kind of go the back stretches of your brain of medical school, what you knew. I'm going to give you an update on the biomarkers and the research criteria that we have. Go over what our current therapies are, some of the new anti-amyloid therapies that we have that have been approved in the past couple of years, and things that are in the pipeline. So again, just so we're on the same page, I like to talk about what dementia is. Patients always ask me, what's the difference between dementia and Alzheimer's disease? And the way I describe it, that dementia is a functional decline, meaning that people have a cognitive problem that progressively gets worse at this day and age. And it causes a decline in their independence. They're having trouble with doing their bills, working, laundry, shopping, cooking. That's what dementia is, whereas mild cognitive impairment, which is another term that we often use, where there is a cognitive problem, but they're independent. They can take care of these things, or maybe with modification or with slight assistance. Whereas normal aging doesn't mean that you're perfect, but there are some changes that happen over time. So some slower processing speed, and I got asked this a lot when we had our presidential candidates, asking what is normal aging in terms of cognitive function. So there may be some slight working memory difficulties, so maybe not 7 digits, for example, maybe 6 digits, and some word finding difficulties. So it's a progression. It doesn't happen overnight. And when I like to remind people that dementia is this umbrella term. Alzheimer's disease, we often equate the two, but Alzheimer's disease is the most common type of dementia, and that's why we often tend to confuse the two. But Lewy body dementia, or dementia with Lewy bodies, is the second most common dementia that you've never heard of. We've got vascular cognitive impairment, frontotemporal dementia, CTE that we hear about in the media a lot. So that's the umbrella term. And we're going to focus today on Alzheimer's disease. Now, every time I give this talk, I have to update these numbers. These numbers are rising constantly. It affects over 7 million Americans. I literally just gave a talk a month ago and said 6.9, and these are just updated a few weeks ago. Over 55 million around the world, and estimated to be 139 million by 2050 because of our aging population. Now, we often think about Alzheimer's disease causing memory loss, and that's the prototypical symptom, and that's the most common early symptom. What you see here, if you're not a neuroradiologist, I'm going to give you a reminder, this is a coronal flare where we see that the hippocampus has atrophied. So that's there. Hippocampus in Greek means seahorse, so that's where we see the atrophy, and that's where the symptoms come from. Here is a sagittal FDG PET. So we're looking at it this way, sagittal FDG PET, where we see hypometabolism in the parietal lobes, and that often correlates with the word finding and navigation difficulty. Now, this little star in the corner, just because I'm giving you background, but things that have been published in the past year or relatively recently. So this was just published a couple of weeks ago, saying that Alzheimer's disease was the 7th leading cause of death in 2022. The numbers come up a few years later, but we can see that things are declining, whereas Alzheimer's disease is continuing to rise. And it actually was the 5th and 6th a few years before COVID came around. And the thing to note that we don't fully understand, it's really become a curiosity of mine, is why women, 2/3 of Alzheimer's disease are women, and we don't really know why. And that's really all ages. We also know, but we don't understand why, African Americans and American Indians have the highest incidence. So this is really looking at the rates of 2000 to 2013. What we do know is that the Alzheimer's pathology happens at this age, 15 to 20 years before we even have symptoms. And to remind us of that pathology, we've got here, I'm in the way, the amyloid plaques. And in the lower right, we've got the tau tangles. And then that causes this neurodegeneration, synaptic loss that we see. And so the classic model that we've used for 15, 20 years now, Cliff Jack, created the schema that, and I'll go over it with you, on the x-axis here is time. And we see the cognitively normal, non-cognitive impairment, and dementia that I talked about. And on the y-axis is the biomarker change. And we know that the first thing changes is that amyloid. That's the first thing that deposits 15 to 20 years before we have symptoms. Over time, then we start to see the tau, I think that's blue-purple, that starts to rise. And then the green, we start to see structural changes. That's the MRI atrophy that I showed you, or hypometabolism on the FDG PET that I showed you. And then as time goes by, we start to see that clinical symptomology. So that's the dark green. So memory is that purple. So you start to see the symptoms and then the functional decline finally. And so most targets for clinical trials and intervention has been in that early MCI stage, because that's when we can start to detect symptoms. And ethically, most of the clinical trials and governing bodies said, hey, you know, we need to sort of see if symptoms can be affected in that stage. Well, in the past few years, we started to recognize we have new biomarkers and we can detect them at different times. So if we compare here on that far left, we still have amyloid rising first. Then you can see that it's the A beta fluid, and that's usually represented by the CSF and that dark red here. And then that magenta purple, we're starting to see that we can detect the amyloid changes with an amyloid PET. And then what's complicated, and I'm going to get through this a little bit in a few slides, is that light blue is this phosphorylated tau fluid. Now it's a bit confusing because it's in plasma, it's a p-tau species, but it's really correlating with this amyloid best. And I'll repeat that again a little bit later. As time goes by in the dark blue, we're starting to see then the changes that we would expect with atrophy, FDG PET, and then the cognitive impairment. So we're starting to see little difficulties or little differences in the biomarker deposition. And what we're recognizing is that it's not just the amyloid and tau that's depositing in the brain, but there are all kinds of pathological pathophysiologies that are occurring in Alzheimer's disease. So we have the amyloid tau in the top left there, but we see some synaptic dysfunction, neuronal injury, we see the microglial activation, and then some evidence of co-pathology that often occurs in Alzheimer's disease. It's not part of the Alzheimer's spectrum, but we can see that co-occurring. And what I'm highlighting here is that we can have biomarkers to detect some of these pathologies now. And so you can see the star in the upper right corner, and that's sort of me to let you know, okay, this is something new. In the past year, a group of experts got together, Cliff Jack and others, and said, hey, we're going to update the research criteria for Alzheimer's disease because of all these biomarkers that we can now use to diagnose and stage the disease. And so what you see is the core 1 biomarkers. Those are the things that sort of develop first, that we can detect first. The core 2 biomarkers are what comes a little bit later, usually reflecting that tau pathology. And then we can see non-specific markers of inflammation, neurodegeneration, neurofilament light chain, GFAP, which is glial fibrillary acidic protein. And then we have markers of co-pathology. We always could tell sort of the vascular cognitive impairment with CT or MRI, But now, actually, we can detect synuclein. And if you don't recall synuclein, that's Parkinson's disease. That's Lewy body disease. We can detect that in CSF and with skin biopsies. So with a lot more regularity, we can be a lot more confirmatory with not only diagnosing Alzheimer's disease with these various biomarkers, but potentially seeing evidence of co-pathology that are quite common. So is this the end-all be-all? No. The international working group got together and said, hey, we don't like this staging. Actually, they didn't really get in a fight. They really sort of said, well, you know, even though you have all these biomarkers and you said we've got this staging system, what the Cliff Jack research criteria had said is that if you've got evidence of amyloid, we're going to call you Alzheimer's disease. Now, you can imagine if someone who's cognitively normal, they may not get the symptoms 15 to 20 years later. But if we're calling someone Alzheimer's disease with amyloid in the brain, is that right? So the international working group agreed with a lot of the staging criteria, but they said, you know, if someone is cognitively unimpaired and you have amyloid in the brain, maybe we're considering you at risk. So there's a little discussion and controversy in the field right now about what the semantics are. You know, and some who are proponents of this Alzheimer's disease diagnosis is say, maybe if you've got cancer, I've got probably oncologists in the room here. If you got a high-grade polyp, if you got evidence of a tumor, we call this cancer. Is that what we need to do? This is Alzheimer's disease. So there's a little controversy in the field about the semantics right now, but we can see that there are ways to detect it. And we've seen upgrades and also synuclein criteria with Lewy body and Parkinson's disease. So just so you know, we've got a lot of these biomarkers available in clinical practice. Some of what I've talked about has to do with things that are available in research, but in clinical practice, what we have here, amyloid PET we've had for quite some time now, but in 2023 in the fall with the approvals of these amyloid antibodies, CMS has now approved amyloid PET scans. So that's becoming more popular in clinical practice. And we have these hybrid ratios of CSF that are quite highly accurate in correlating with these amyloid PET. And then I highlight in this dashed line here is these blood-based biomarkers that are really coming and rapidly developing in the past year or so. So just to briefly review what the amyloid PETs are, these got approved, FDA approved, these 3 tracers are FDA approved for amyloid PET, mainly because patients who were enrolled, they were in hospice close to the time of death, and they highly correlated to autopsy. And what's relatively new is that prior to this, the Centiloid scale, the readings for the amyloid PET were very qualitative. It's positive or negative. And what we've done in research is say, hey, we really need a more quantitative evaluation of when someone has amyloid in the brain. There may be someone who's on the border. And so what we've seen in research and now is implemented at Stanford because of our amyloid antibodies and discussions with our nuclear medicine colleagues and friends and neuroradiology is that we've implemented these scales, and there are several sites around the country that do this. The Centiloid scale is sort of to say, hey, on average, people who have Alzheimer's disease have about 100 on that Centiloid scale. People are considered negative or usually less than 25. So you get more of a qualitative and quantitative value for these amyloid PET scans so that we can say if we are going to start using an amyloid therapy, how far have we changed? Tau PET has been around for a while, also at least for 5 years. And it gives more of a qualitative value to the diagnosis. It's not currently being covered by insurance, but we really see the value when someone has symptoms that are memory loss. We see the tau deposition near that hippocampus entorhinal cortex associated with the symptoms. Some people who have more language difficulty, we call that a logopenic primary and progressive aphasia, and we see the tau burden more in that left hemisphere in the inferior parietal lobe. So we can see that gives us a bit more information, and we see some of the data with these new antibodies that people who have less tau burden may actually benefit more with the treatments. What's been around is the CSF for the past decade. It's been covered by insurance and relatively helpful because it gives you a lot of data, not just amyloid or tau, but it can give you a total tau, which is a marker of neurodegeneration. And what has been relatively new in the past few years are these ratios, and gives you a bit more accuracy in determining whether there's amyloid presence or not. And so now coming to the plasma p-tau, there's been a lot of different p-tau species that have been looked at in the past 3 to 5 years. And what's really risen to the top is this p-tau 217. What you can see from this graph is that there are different companies that have these p-tau217s, and then people also looked at p-tau181 and really kind of looking at the comparison to amyloid PET. They didn't compare to pathology, but they compared to amyloid PET and see how accurate it is. You might say, well, tau is in its name. Why are we comparing to amyloid PET? They do find that the p-tau does correlate with amyloid and tau status, but actually it's more accurately reflective of the amyloid status. So again, that's in that first core 1 biomarker, even though tau is circulating in the blood, it tends to correlate with that core 1, what deposits first. So we tend to think, at least in the current scientific hypothesis, that maybe this is not only concordant with all of these other biomarkers, but it might predict future conversion. That because what's circulating in the blood with the tau is saying that's what's going to future deposit in the brain as a tau PET. So potentially these p-tau species, whether that's a ratio of p-tau217 and A-beta42 or other combination, it can be relatively accurate for amyloid PET and potentially predicting future decline. The caveats with these blood-based biomarkers is that one, this is my way of not having words, that people who have renal dysfunction might have a false positive. People who have MI and stroke, we're not sure if they're going to be false positive or false negatives. People who have, this is my way of showing a high BMI, may also have a false negative. And that has not been validated in a lot of ethnicities, racial groups as of yet, so not in a lot of diverse populations. The current thinking, though, is that the slight false positives or false negatives are going to be very minor, and that some early literature from other groups out of different countries are that it's quite well validated. And so there's been a lot of discussion in the past year about what's required for a blood-based biomarker, that most likely having a 2-point cutoff where you're saying, hey, and I think most of you who use markers for, say, cholesterol, other things, will have a clear representation. This is clearly positive, this is clearly negative, but when you're in intermediate range, maybe that's when we need to do a more confirmatory test with a PET scan, CSF, or other. And not to be dismissive of some of the other sort of pathophysiological processes that we talked about, we say that, say, MTBR, this is relatively new again, plasma MTBR, that's microtubule binding region tau, 243 is a relatively new marker, only in research right now, that potentially could be representative of that tau protein. So then when we think about other neuropathological process, neurofilament light is something that rises in Alzheimer's disease and is a marker of neurodegeneration. We can see that in other neurodegenerative diseases, so not specific to Alzheimer's disease, but that can rise. And GFAP, I mentioned earlier, also a measure of neuroinflammation. So we can get sort of a panel of markers potentially and say, hey, you've got all of these features. So how could we sort of include this as a panel if someone were to come in and we say, hey, let's get a blood test. I want to know what my likelihood of Alzheimer's is right now for the future. One of my colleagues who's an instructor in Beth Mormino and Katja Andreasen's lab just looked at this sort of process and said, hey, we've got all these sort of neuropathological processes. And he took all of the blood samples that were present in an Alzheimer's disease research center and said, hey, you know, can we measure these things in the blood? And he measured all of these features and found sort of a profile. And you can sort of see that there are people who are negative for all of them. And then there are people who are positive just for sort of the amyloid. And then some people who are positive for amyloid and GFAP. And then the amyloid, GFAP, and tau. And then for amyloid, GFAP, tau, and neurofilament light. But then there were some that didn't quite fit who were GFAP positive or amyloid and tau positive. And what was interesting when I saw this, he just presented this, you know, at a meeting a couple weeks ago. It's unpublished data, but really interesting to say, okay, it seems like there's a clear pattern that is a majority of the group that tends to happen, that we see similar to what you see in Cliff Jack's model, but not exactly the same, that A beta is what happens first, but almost that GFAP is a prerequisite for the subsequent neuropathological processes. He also found that those groups that had the GFAP were more likely to have a decline in function when followed over time. So let me take a moment. That's some of the biomarkers and then diagnosis. So a lot has happened in the past couple of years in terms of diagnostic testing for Alzheimer's disease and even neurodegenerative diseases. But let's get to some of the treatment, the sort of second half. We know that there have been these drugs that have been around for over a decade. What I had done in my practice was say, okay, let's give you one of the cholinesterase inhibitors, and we haven't had much since then. And this is sort of the approval that's happened. It's been sort of over a decade. And then in the past sort of 5 years, we've seen a rise in some approvals for therapies. And really a majority that's been hitting the press and really has changed our field a lot is the disease-modifying therapies for Alzheimer's disease. It started off with aducanumab, which then was announced last year that they were moving it from the market for some of the various reasons in terms of side effects and controversy with its FDA approval. But lecanemab was approved in 2023, and then donanemab was approved last year. As a reminder that we know that we can't cure Alzheimer's disease, and without medications, people get worse. The symptomatic therapies, such as the cholinesterase inhibitors, were really delaying that slope. And so I really tried to set those expectations for my patients when I prescribed these drugs to say, hey, we're not going to make you better. You're still going to get worse, and you won't know that you're getting worse at a slower sort of rate, but the same slope. Whereas these disease-modifying therapies, we're hoping to attenuate that slope with these potential new amyloid antibodies. So lecanemab, let me give you some of the data. It's not that new, but published in 2023, why these anti-amyloid therapies were approved. Now, in clinical trials, so this was a clinical trial of 1,800 patients with mild cognitive impairment and mild dementia due to Alzheimer's disease. They had to prove that they had Alzheimer's disease by getting an amyloid PET at baseline. And what we saw with these trials is that there was what we call target engagement. The drug reached the target, which is amyloid, and then removed it. So you can just see clearly in the placebo in the blue compared to the treatment group, there's reduction in the amyloid burden as detected by the PET scan. So we can see really that there's a decline there with those drugs. Very exciting, but who cares if you remove it, there's no change in clinical function. And what you see here, the clinical dementia rating scale, the CDR, sum of boxes is to measure whether or not someone can do their shopping, their cooking, their independent factors. And you can see again, compared to the placebo in blue versus the yellow with the treatment, there's less decline over time. So that attenuation of that slope. But the controversy in the field is, does that really change much? Is that really clinically meaningful? Some of my own colleagues in my own division have written op-ed editorials. I didn't cite any of them here, but have written op-ed editorials, but how, I don't know that this is worth it, essentially. And what papers have shown is that this is really changing sort of that disease process on average, maybe 5 months for lecanemab here. So is that beneficial? But that was over 18 months. The trial was over 18 months. Similar findings for donanemab. We see again, amyloid PET reduction with the clinical trial and the treatment group versus the placebo group. And again, less decline over time with the CDR sum of boxes. And essentially on average delayed, progression by 7.5 months. So the way I say it to patients is about on average for both of these drugs, maybe 6 months. But there are differences. Lecanemab is targeting the protofibrils and the plaques. And so the lecanemab is actually given every 2 weeks as an infusion, sort of indefinitely, because protofibrils are continuing to be made, whereas donanemab is targeting the plaques. And so in this clinical trial, people who were detected as being amyloid negative, they were able to switch to placebo. And so about 76% of patients were able to switch to placebo at that 18-month mark. So you can essentially stop treatment. And what we can see from other data is that it's sort of these medications have a risk reduction to the next clinical stage. So it's, again, not a cure, attenuates the slope, not a drastic amount, but is the first of the kind in our Alzheimer's therapies. And well, what are the side effects? What's the burden here? And this is what the patients ask. What's the burden? Well, they're infusion reactions. They're an infusion-based drug. Lecanemab had submitted for a subcutaneous injection in the fall of 2024, so that might modify things in the future. So about 25% with lecanemab, just under 10% with donanemab. They tend to happen the first couple infusions and then resolve on its own. But what we hear about in the media and the concern about a lot of us is ARIA, and it stands for amyloid-related imaging abnormality. And there are two versions, ARIA-E for edema or effusion, and ARIA-H for hemorrhage. So for behavioral neurologists, we're not used to intervention. This is a huge deal. We're not really ready to deal with side effects. What you can see in the edema, that's sort of a severe, but what we see that's different, and you might say, hey, you know, someone who has these like white spots on the brain, how are they different than what's around the ventricles, what we call small vessel ischemic disease that you often see in reports? And it's usually because it's cortical, there's gyral swelling associated with it, but essentially we need experts that can read these MRIs because there's some subtleties. And similarly here with microhemorrhages, these are little dots, tiny hemorrhages, often asymptomatic, or superficial siderosis, sort of like a linear sort of bleed on the surface of the brain, but there can be macro hemorrhages also. And what we see is that there are different rates of ARIA with a different drug, and what I'll just highlight here is that with these monoclonal antibodies, these are the most common side effects. Their majority of them are asymptomatic. So about 75% of them, though there have been serious and fatalities that have occurred with it, they typically occur in the first 6 months, though there have been reports up to 12 months as well. So really, it's as you're titrating up is when that ARIA tends to occur. And the ApoE4, and I didn't talk about ApoE4, but that is a higher risk genotype for developing Alzheimer's disease. And so having one or two copies increases the risk of ARIA. And what we see here for lecanemab and donanemab, there are different rates there. I'll talk about this in a second with this modified titration, but I wanted to mention this ApoE4 copy number that increases the risk. So you can just see from the graph here in the top row, the non-carriers who don't have ApoE4, the risk is lower versus then someone who's a homozygote, 30%, 50%. So you can see where in the US, these were FDA approved. In Europe, donanemab was not approved, and in some institutions and insurance companies do not approve these drugs for homozygotes because the risk is greater. What's highlighted here is that just published a month ago was donanemab's modified titration. So a slower titration than was done in the clinical trial, the phase 3 trial, so it was just much slower. And you could see that there was a lower ARIA rate, a bit more on par with lecanemab. So what we see is that for overall, these drugs are essentially the first of its kind. We're going to be more modifications as time goes on, but the field is rapidly changing. Because of ARIA, and majority is asymptomatic, you can see that we've got to do a lot of MRIs. It's not detected by CT scan. So we really need to do MRIs quite frequently. This is impossible to memorize, but essentially those first 6 months is when we really need to do those MRIs, but there are some recommendations to do one before the year mark. So who is right and who isn't right for treatment? Well, you can imagine someone who cannot get an MRI is not someone that we should be giving these therapies because we won't be able to detect the ARIA rate. But you can imagine those people who are at risk for ARIA. So those may be people who have underlying cerebral angiopathy, amyloid angiopathy, so people who have baseline microhemorrhages. But even though in the clinical trials, people who were allowed to be on anticoagulants, we've seen some fatalities with this. So in particular, people who come in with a stroke on, say, lecanemab or donanemab, and given TNK or TPA and then had a fatality. So the current appropriate use recommendations are to not give these therapies if they're on anticoagulation. And you can imagine cardiologists, my stroke colleagues say, well, this is a life-saving therapy. There's a lot of discussion, I think, about the individual, not only patient preference, but the risks for those who maybe need to be on anticoagulation or high risk for stroke. But we also need to educate our colleagues about if someone comes into the ER with what looks like stroke-like symptoms, we need to do an MRI as opposed to CT. So there's a change in our field that's causing a change and repercussions throughout other fields too. And essentially people who we don't know the factors with people who are on other immune conditions and things like that. We've implemented these therapies at Stanford, and we have required a lot of resources. You can imagine with discussions with different groups, experts, neuroradiologists, nuclear medicine, genetic counseling, infusion center. You can imagine having access to these beds, especially if this drug is given forever, every 2 weeks, and then modified to every 4 weeks. There's a lot that goes on with this. What's exciting, though, is not just these anti-amyloid therapies. You know, this is the first of its kind, and I often sort of equate it. Now, oncologists in the room can tell me how wrong I am, but I tend to equate it to something like the first chemotherapies because it's the first of its kind. There's a lot of side effects. There's a whole host of activities and protocols associated with it because if they come to the infusion center, talk to families, make sure they have a support system for getting this. But in terms of the therapies, now Jeff Cummings publishes this update every year, usually by April. So this is last year's. He hasn't published this one yet. But it really shows us the pipeline of the clinical trials in Alzheimer's disease. So this is a year old, but the phase 3 trials are in the center circle. The phase 1 trials are in the outside circle. If you're not familiar with clinical trials, phase 1 is sort of first in human, looking for safety. Phase 2 is maybe dose testing in the disease population. Phase 3 is in that disease population, we're looking for efficacy. And what you see red, the color red here is for amyloid therapies. And in years past, it was all red. We're all thinking amyloid, that's it. You know, now that we have some, there are a lot of foundations, scientists, grant funding mechanisms that say we need to find other mechanisms besides amyloid. Sure, we need to refine these anti-amyloid therapies so it's safer, but what other mechanisms are there? So it's really exciting that we're seeing development in that way. One of the things that I'm working on is I'm a global PI for this clinical trial for a phosphodiesterase 5 inhibitor. And for those of you who don't know what that is, that's an erectile dysfunction drug. So what we've seen is these papers, again, it's not causal, but associations of people on PDE5 inhibitors and the decreased risk for developing Alzheimer's disease and dementia. So that sort of prompted some of the work in the PDE5 inhibitor realm, and that actually not just for erectile dysfunction and not just vascular, say, permeability, but there may be some neurologic benefits with these PDE5 inhibitors. So this particular drug is in a phase 3 clinical trial that's global, in which they're just about to, or we're just about to finish completing enrollment. And it's global, about 1150 was the goal, but it's about at 1200 right now. So very exciting that there's other work going on. But when we think about other trials and thinking about the future, I was lucky enough to be part of a task force thinking about combination therapies. Because I talked about a lot of different pathologies early on. I don't know if you were asleep during that part, but there was amyloid and tau and neurodegeneration and inflammation. How do we target all of those to really get at the disease? You know, just one amyloid antibody is not going to be it. Everyone sort of recognizes that. So we need to get to these combination therapies, but not only which drug, when do we intervene? You can see that these changes, the pathological changes, happen at different stages in the time points. And so what I showed in this task force is saying, well, when we think about combination therapies, there's sort of challenges and opportunities. One, obviously, is multiple mechanism, a synergistic effect. But with the trials, it's really hard to think about what's the safety of each agent, you know, what's the efficacy of each agent? How do we know that they're working, you know? So when we go back to this schema, at what point do we intervene? Are we thinking about prevention? Are we thinking about symptomatic? And another way to show it, again, is Jeff Cummings, where we see the 6 stages of Alzheimer's disease. In the later stages, we're thinking more about symptomatic. But in these early cognitively unimpaired, where we have evidence of pathology, should we be intervening? And are we intervening to prevent or to target that neuropathological process? You can see it's quite complicated. So when I went into this task force, I said, I need to learn from my colleagues. What can I do and read about oncology combination trials? What can I do to look at my colleagues in HIV? How did they find therapies and what were the trials that they did? So I won't go over that entire talk, but one study that I sort of, again, someone asked me, are you an oncologist? Now, I don't want to offend the oncologists in the room, but I really did a lot of research to look at those clinical trials to understand how did they start to think about intervention. So this is one trial that I highlighted in which this is non-small cell lung cancer, where they had sequential versus concurrent sequential therapy. So you can see sort of in the top row, it's a platinum-based chemotherapy for these patients, small n's, and then the platinum-based chemotherapy with concurrent, now I don't know how to pronounce it, nivolumab, and then that alone. Whereas in the bottom row, we have the platinum-based chemotherapy, and then nivolumab. And then I think about, well, what about Alzheimer's? Could we have amyloid and then a concurrent treatment, and then you follow the tau? And then I predicted we would publish that, or it'd be subsequent. So we did publish sort of the thinkings from that task force that just came out, I think, a few weeks ago. No resolutions, but a lot of ideas and questions for what we're going to do. But you can see that people are thinking about it, amyloid and tau first, but there may be inflammatory types of pathophysiological processes and neurodegeneration processes as well. So getting back to the screening, I hope I've given you some ideas about whether or not we should be doing screening for patients. Now, just published, I think a week ago, as I was updating these slides, was the Alzheimer's Association conducted a study of people 45 years and older and said, hey, what do you want to know? Do you want to know if you have Alzheimer's disease? And not as much as, say, cancer screening and blood pressure screening, but 59% want some cognitive screening. So we've thought about biomarker testing for the past decade. We've thought about, well, we really don't want to do biomarkers unless people have objective evidence of cognitive impairment. That makes sense, right? And you're going to do a test really only if that test is going to help you with the diagnosis, help you with management, and particularly if we're thinking about an anti-amyloid therapy. These are the biomarkers I talked about earlier. There's pros and cons for each of them. Essentially, cost, invasiveness, compatibility and accuracy. So there's a lot that's happening and changing so rapidly that it's hard for us in the field to sort of keep up with what's available. And when we think about these blood-based biomarkers, a working group on blood-based biomarker, that's a lot to say quickly, thought about these same things and really recommended for the secondary care, so the experts, really, again, to follow that same pattern that you really only do these blood-based biomarkers after you've had a comprehensive assessment, and whether you think this test would be very beneficial in changing management or diagnosis. But in the primary care setting, they have a little bit of a different guidance that it really should be for 55 years or older. And if it's younger than 55, you want a special population where it really looks like it's, because it can happen in under 55, but it really should look like it's Alzheimer's disease or a syndrome that matches with it, or clear family history of early onset, like these genetic types. And then we have different requirements for a triage test versus a confirmatory test, and really thinking about all of these considerations and what the pretest probability is, because there's a lot that's changing, and a lot of people are starting to order this now. I'm seeing that referrals from other doctors even after a PET was done. So really thinking about why we need to do that. But we're also getting into a space of prevention. So this clinical trial, the A345, is using lecanemab in people who are cognitively normal but have evidence of amyloid in the brain, and seeing if we can prevent disease. There's another one using donanemab called Trailblazer-ALZ 3 that also is happening. So in the next few years, we're going to get readouts of whether giving someone an amyloid antibody will prevent disease. That could be exciting. It could break our insurance system. We don't know, because these are costly and time-consuming, but that would help us understand whether doing a screening blood-based biomarker is helpful or not. I do want to end with some positive notes, and I do talk with my patients a lot, whether or not they're considering these therapies. I talk about the risk factors and what we can do now. We know age is the biggest risk factor. We can't change that. ApoE4 I mentioned is a risk factor. We can't change our genetics, but there are certain things that we can, right? Vascular disease, head trauma, low education, sleep factor, and now pollution is one. And I really like this, again, published recently by the Alzheimer's Association, these modifiable risk factors. Really, I really try to stress that. And this is a study I quoted to my patients early in my career. Small number, 120 people who are older adults, average 67, who exercised on a treadmill versus stretched. And that exercise group, as you can imagine, had not the decline in hippocampal volume, like the stretching group, had an increase in hippocampal volume and did better on memory tests. Small study, but so many exercise studies, whether it's cardio or Tai Chi or dancing. There's so many studies that show the benefits of exercise, whether it's BDNF, brain-derived neurotrophic factor, or others. How nature is helpful. This is a study of college students who went for a walk in the park versus in downtown. And they did better on executive function tests. That's a multitasking type of test, 1A, 2B, 3C, et cetera. and they felt better, right? Isn't that great? And then this study of almost 4,000 people looking at lifestyle measures. And this is what's interesting. I like to mention this to people who are worried about their genes. Because what you can kind of expect in people who have good lifestyle, you healthy eating, exercise, socialize, keeping your brain active, that those who, and they separated the groups by those who are on ApoE4 carriers or not carriers. And this is cognitive score over time. And then the ApoE4 non-carriers were better off than the carriers. But what you can see here is that essentially, or the exercise groups, let me explain it again. The exercise group and the healthy diet, all that stuff were better off in that dashed line compared to those who weren't. But these are and those are ApoE4 non-carriers. These are ApoE4 carriers, and the separation also exists, that the healthy lifestyle is better off than the non-healthy lifestyle. That's good. But what's interesting is that the dashed line, the beneficial group in the ApoE4 carriers, about the same as the non-dashed line in the non-carriers, suggesting that potentially you're sort of negating that extra risk with the ApoE4 genotype, that not all of your genes are determined for you. So that's really exciting. Some people are sleepy in this room, I'm so sorry, but sleep does affect cognitive function. You need to get more sleep at night. So many studies have shown that whether it's the amount of sleep, there's less amyloid burden if you sleep more. If you have better quality sleep, maybe even less tau buildup. So many studies are showing how important sleep is. And because of my education that I like to do with communities and others about brain health and lifestyle, I was lucky enough to be asked to talk to Chris Hemsworth about his brain. It's probably good, right? Well, if you did watch the show, this is not to tout the show, but Dr. Dunn asked me to sort of talk a little bit about some of my adventures. But it's really fun to talk about a healthy lifestyle, not when you get older, but your entire life, right? I think your kids, family members, how important it is. He's got 2 ApoE4 genes, so he's high risk. And we weren't sure if we were going to talk about it in the show, but we did end up talking about it. The premise of my episode is to talk to him about his brain, how to keep it healthy. And I said, go for a walk in the outback without a device. So I'm just going to play you a clip. So in conclusion, I kind of hate conclusion bullets because you should have been listening all along anyway. So a couple just baseline things. There's been rapid developments in blood-based biomarker testing for Alzheimer's disease. And their standard of care for diagnosing and treating Alzheimer's disease and neurodegenerative diseases overall may be changing. And so I then pose that question back to you, as I did in the beginning. How would you counsel your patients who may want this type of testing? So with that, thank you so much for your attention.
Thank you. Thank you so much. What a treat. I see Dr. Chang has a question. So actually, now I need help with the mics.
Hi. First, thank you so much for a wonderful talk, and even more, thank you for your work in the field and what you're doing for our patients. So I'm a family doctor, and my panel is mostly geriatric. It didn't used to be, but we all got old. So I'll give you a case, and I'd love your thoughts on it. So I have one of them is a early 70s woman with a family history of Alzheimer's with unmistakable mild to moderate cognitive impairment. Family notices, she denies anything. And of course, I recommended referral and imaging and workup. And they did some research and they came back and they said, you know, as far as we can tell, there's nothing out there that's really going to substantially change the course of the disease, its impact on our life or our quality of life. And so we don't want it. And I didn't have the heart to insist because my impression, and this talk has not convinced me that I'm wrong, is that they're basically right, that regardless, their course would be decline, and that they could spend their next 5 years in and out of MRI machines, or they could just optimize the quality of the life that they have.
Yeah.
Or how would you advise me?
Yeah, I mean, I would tend to agree, but again, it's a patient and family decision with you as the provider. And so I think I compared this to chemotherapy again, someone who has sort of like a treatable cancer, but not fixable cancer, it can maybe extend quality of life for a little bit. With one of the drugs, lecanemab, it's indefinite at this point. With donanemab, it's a finite, meaning that once the amyloid PET is negative, so it's not 5 years of MRIs, but it is essentially true that, say, we're changing the disease slope. Over those 18 months of those trials, you see that change of 7.5 months. We don't have that long-term, does it continue to separate over time? So it may be that if, and I would say in my patient population, the younger patients are the ones that are more aggressive. 50-year-olds, 55-year-olds that say, I've got more to lose. I really want to do everything I can. Maybe an 85-year-old will have less likely, I don't know how much time left anyway, not to be ageist, but their own personal decision. I want to spend my time with family, but again, everybody has their own decision. So we're very much at this inflection point of treatments. It's the first iteration. And even the first one, aducanumab, was removed from the market. So essentially, we're going to see refinements over time, but it's that family decision. The only thing I would say in terms of doing the testing is say, we're looking for things that we can fix too. Let's confirm whether you haven't had a big, large stroke that's contributing. Let's make sure you don't have untreated OSA. Let's make sure that there isn't some other depression or anxiety that's exacerbating this, or let's take a look at all of these medical factors to make sure that we're not missing things that could be exacerbating it and supporting them as much as possible. So, yeah.
Dr. Lewis?
Great presentation. I had 2 questions in follow-up to that second study where there was a finite time period for the treatment for the phase 3 study. The first is, are they planning to do an analysis looking to see if there's a legacy effect so that after the conclusion of the trial, kind of, a year or 2 years later, see if the curves continue to separate even off study drug? And then the second question is, has anyone looked at kind of, if you will, a pure Alzheimer's patient? And what I mean by that is, as you know, there are so many different ways to get to dementia. And so if you have vascular risk factors and others that could cause cognitive impairment as well, look at the person who has isolated kind of Alzheimer's without the comorbid conditions that are predictors and see if the magnitude or the slope would be different.
I love these questions. What's your specialty?
Cardiology.
I love it. Okay, so, well, one, in terms of your first question, there are open label extension trials, portions of both of those phase 3 trials that are still ongoing. We have a couple patients in those trials ongoing right now. And some of the early presentations at conferences hasn't been published as of yet, is there's continued separation over time. So we are seeing that continued benefit. How much is hard to say. And that there were some more delays and COVID, et cetera, that there was no catch up. So this sort of, and then comparisons to sort of observational cohorts that weren't placebo groups traditionally in trial, but that they aren't catching up to. So there's continued benefit over time. What I didn't show today is that some of the data that's been presented also is that early stage disease, pathophysiological stage, meaning less tau burden or less amyloid burden, there was actually more of a separation, so more benefit. So again, getting at the point that maybe the sooner we treat, the more likely they're going to benefit too. And then your second question about pure Alzheimer's disease, in the trials, the exclusion criteria is that no big strokes, not a lot of vascular disease, no other neurological conditions that could, but they weren't routinely doing, say, synuclein and other types of tests that are now available. So there could have been some that snuck in terms of Lewy body disease, but most likely not a large amount of vascular disease. So, but I think your point is something that I feel very strongly in the field too, that now that we can do all these biomarkers, we should be doing them in these clinical trials and research settings to get as pure, or maybe to be more inclusive, we include everybody, but do post-hoc analysis and segregate it out to see if those patients still benefit. So for one, I didn't mention this, but Lewy body is another passion of mine. And about 50% of patients with Lewy body also have Alzheimer's disease. And I'll see them in my clinic. I can test for it now with a skin biopsy or CSF. And are they going to benefit? Are they going to be at more risk with these amyloid antibodies? So we need to answer that, because their patients say, I want this. I have amyloid in my brain. I got tested somewhere. So we don't know. But most of those trials had as pure as possible that they were thinking about. Thanks.
More questions than we have time for. I'm going to take the liberty of going to one Zoom question because I'm curious about your take on this. Can you tell us the shingles vaccine story?
I don't know if Pascal's here. I met with him recently, but he published, and so I'm not super familiar with this, but I did read the Nature Medicine paper that was published, I think, maybe last month or something. But what was interesting that he did is very, very exciting, that he looked at people who in Wales, it was the Nature paper, but there's another paper that just came out too. He looked at people in Wales, and there was a cutoff age for who could get the shingles vaccine. It was a live attenuated vaccine, so you had to be 80. So he compared sort of the groups of those who could and those who didn't, who are only a week in age apart, so not a lot of different comorbidities, and found that there was a decreased association of dementia and Alzheimer's disease. So rather than just these retrospective, oh, we see a difference, but because of that very close time point, very exciting. It's again, live attenuated. So I'm talking to him about what we can do next, yeah.
And I'll take the liberty of one more. Could you speak a little more about the divide between women and men?
Oh, yeah. Wendy knows all my secrets. So yeah, we don't really know. So one of my colleagues, Mike Grachus, he studies genetics. Several years ago, he published a paper finding that women who had ApoE4 were more likely to convert to Alzheimer's disease than men with the ApoE4. Is that part of it? We know, 2/3 of Alzheimer's disease are women. And does that have to do with hormones and menopause? One exciting thing, I just submitted a grant, but I don't know if I'll get it, to look at these with these blood-based biomarkers and see through the menopause transition, are there changes that we can detect and potentially even implement as they're getting hormone treatment or not getting hormone treatment. So I think there's a lot more to understand, not only with just Alzheimer's, we're treating it as a monolith. It's just like all cancer is the same. And you're like, that's not true. All Alzheimer's is not the same. They're 55-year-olds, they're 90-year-olds, there are comorbidities, but women are different. They're different ethnicities that are more at risk too. So we need to get at that precision medicine the way you guys have been, and we're trying to learn from you to do these trials so we can get at our patients a lot better. So.
I'll let Dr. Stevenson have the last question.
Yeah, thank you. Let's speak loudly. Oh, they want on Zoom. Okay. All right. Thanks, Mike.
Oh, I see it's like a little low on battery.
Yeah.
Go ahead.
Let's see. I had two, but since it's the last one, I'll have to choose. I work at the VA, and I often run into patients who are told that they have Alzheimer's even after pretty extensive workups, like CSF tau studies. My understanding is that pathologically and on imaging and clinically, it's really tough to distinguish chronic traumatic encephalopathy from Alzheimer's pathology. And I guess I'm wondering, is there any objective way of making the distinction? Because, that could impact benefits eligibility for, hundreds of thousands of people. Yeah.
Yeah, good question. So I sort of mentioned CTE in that umbrella of dementia. We know it's a tauopathy, so a tau protein, a little different than the tau that we see in Alzheimer's disease. The proteins that we see in Alzheimer's disease are a 3 and 4 repeat combination tau, whereas the CTE is different than that. But the problem with CTE is that we don't have a biomarker. So we can use all these biomarkers that we talked about to confirm Alzheimer's disease, but it doesn't rule in or rule out comorbid CTE. And we know head trauma is an increased risk for Alzheimer's disease and dementia overall. I did show one slide on that MTBR, the microtubule binding region 243 plasma. So that was sort of looking at tau in Alzheimer's disease. But my sense is that in the next few years, we're going to hopefully get some more biomarkers for tau-related diseases, tauopathies that are PSP, progressive supranuclear palsy, corticobasal degeneration, CTE, Pick's disease, others that we can be more certain. But as of right now, it's only pathology. So.
Great. Thank you so much. There are more questions that we have time for, but let's thank Dr. Sha for the presentation.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. please visit us at med.stanford.edu.